Welcome to This Week in Surgery, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Surgery has you covered. Our podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the surgical field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Surgery, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine, including in the operating room. This week in surgery, we will be discussing recently published articles. First, Annals of Surgery. Implementing Enhanced Recovery Pathways, a qualitative study of factors that distinguished higher performing hospitals. Objective. The aim of this study was to explore barriers and facilitators to implementing enhanced recovery pathways, with a focus on identifying factors that distinguished hospitals achieving greater levels of implementation success. Background. Despite the clinical effectiveness of enhanced recovery pathways, the implementation of these complex interventions varies widely. While there is a growing list of contextual factors that may affect implementation, little is known about which factors distinguish between higher and lower levels of implementation success. Methods. We conducted in-depth interviews with 168 perioperative leaders, clinicians, and staff from 8 U.S. hospitals participating in the Agency for Healthcare Research and Quality Safety Program for Improving Surgical Care and Recovery. Guided by the Consolidated Framework for Implementation Research, we coded interview transcripts and conducted a thematic analysis of implementation barriers and facilitators. We also rated the perceived effect of factors on different levels of implementation success, as measured by hospitals' adherence with 9 process measures over time. Results. Across all hospitals, factors with a consistently positive effect on implementation included information sharing practices and the implementation processes of planning and engaging. Consistently negative factors included the complexity of the pathway itself, hospitals' infrastructure, and the implementation process of executing, particularly in altering electronic health record systems. Hospitals with the greatest improvement in process measure adherence were distinguished by clinicians' positive knowledge and beliefs about pathways and strong leadership support from both clinicians and executives. Conclusion. We draw upon diverse perspectives from across the perioperative continuum of care to qualitatively describe implementation factors most strongly associated with successful implementation of enhanced recovery pathways. Neuropathic pain after burn injury, a severe and common problem in recovery. Objective. The aim of this study was to address the limited understanding of neuropathic pain, NP, among burn survivors by comprehensively examining its prevalence and related factors on a national scale using the Burn Model System, BMS, national database. Background. NP is a common but underexplored complaint among burn survivors, greatly affecting their quality of life and functionality well beyond the initial injury. Existing data on NP and its consequences in burn survivors are limited to select single-institution studies, lacking a comprehensive national perspective. Methods. The BMS National Database was queried to identify burn patients responding to NP-related questions at enrollment, 6 months, 12 months, 2 years, and 5 years post-injury. Descriptive statistics and regression analyses were used to explore associations between demographic/clinical characteristics and self-reported NP at different time points. Results. There were 915 patients included for analysis. At discharge, 66.5% of patients experienced NP in their burn scars. Those with NP had significantly higher patient-reported outcomes: Measurement Information System 29, PROMIS 29, Pain Inference, itch, anxiety, depression, and sleep disturbance scores, and were less able to partake in social roles. Multiple logistic regression revealed male sex, % total body surface area, and moderate to severe pain as predictors of NP at 6 months. At 12 months, % total body surface area and moderate to severe pain remained significant predictors, while ethnicity and employment status emerged as significant predictors at 24 months. Conclusions. This study highlights the significant prevalence of NP in burn patients and its adverse impacts on their physical, psychological, and social well-being. The findings underscore the necessity of a comprehensive approach to NP treatment, addressing both physical symptoms and psychosocial factors. Association between whole blood transfusion and mortality among injured pediatric patients. Objective. The aim of this study was to assess the association between whole blood, WB, and mortality among injured children who received immediate blood transfusion. Background. The use of WB for transfusion therapy in trauma has been revisited, and recent studies have reported an association between WB and improved survival among adults. However, evidence of a similar association lacks in children. Methods. We performed a retrospective cohort study from the American College of Surgeons Trauma Quality Improvement Program, ACS TQIP, between 2020 and 2021. Patients were aged less than or equal to 16 years and had immediate blood transfusion within 4 hours of hospital arrival. Survival at 24 hours and 30 days were compared after creating 1-to-1 propensity score matched cohorts, matching for demographics, injury type, vital signs on admission, trauma severity scores, hemorrhage control procedures, hospital characteristics, and the need for massive transfusion. Results. A total of 2,729 patients were eligible for analysis. The median age was 14 years, interquartile range, 8 to 16 years, 1862, 68.2%, patients were male, and 1,207, 44.2%, patients were white. A total of 319, 11.7%, patients received WB. After a 1-to-1 ratio propensity score matching, 318 matched pairs were compared. WB transfusion was associated with improved survival at 24 hours, demonstrating a 42% lower risk of mortality, hazard ratio 0.58, 95% C, 0.34 to 0.98, p equals 0.042. Similarly, the survival benefit associated with WB transfusion remained consistent at 30 days, hazard ratio 0.65, 95% C, 0.46 to 0.90, p equals 0.011. Conclusion. The use of WB was associated with improved survival among injured pediatric patients requiring immediate transfusion. Two days versus 5 days of postoperative antibiotics for complex appendicitis, cost analysis of a randomized, non-inferiority trial. Objective. To compare costs for 2 days versus 5 days of postoperative antibiotics within the antibiotics after an appendectomy in complex appendicitis trial. Background. Recent studies suggest that restrictive antibiotic use leads to a significant reduction in hospital stays without compromising patient safety. Its potential effect on societal costs remains underexplored. Methods. This was a pragmatic, open-label, multi-center clinical trial powered for non-inferiority. Patients with complex appendicitis, age greater than or equal to 8 years, were randomly allocated to 2 days or 5 days of intravenous antibiotics after appendectomy. Patient inclusion lasted from June 2017 to June 2021 in 15 Dutch hospitals. The final follow-up was on September 1, 2021. The primary trial endpoint was a composite endpoint of infectious complications and mortality within 90 days. In the present study, the main outcome measures were overall societal costs, comprising direct health care costs and costs related to productivity loss, and cost-effectiveness. Direct health care costs were recorded based on data in the electronic patient files, complemented by a telephone follow-up at 90 days. In addition, data on loss of productivity were acquired through the validated productivity cost questionnaire at 4 weeks after surgery. Cost estimates were based on prices for the year 2019. Results. In total, 1,005 patients were evaluated in the intention to treat analysis, 502 patients were allocated to the 2-day group and 503 to the 5-day group. The mean difference in overall societal costs was €625, 95% C, €958 to €278 to the advantage of the 2-day group. This difference was largely explained by reduced hospital stay. Productivity losses were similar between the study groups. Restricting postoperative antibiotics to 2 days was cost-effective, with estimated cost savings of €31,117 per additional infectious complication. Conclusions: 2 days of postoperative antibiotics for complex appendicitis results in a statistically significant and relevant cost reduction, as compared with 5 days. Findings apply to laparoscopic appendectomy in a well-resourced healthcare setting. Two days versus 5 days of postoperative antibiotics for complex appendicitis, cost analysis of a randomized, non-inferiority trial. Objective: to compare costs for 2 days versus 5 days of postoperative antibiotics within the antibiotics after an appendectomy in complex appendicitis trial. Background: recent studies suggest that restrictive antibiotic use leads to a significant reduction in hospital stays without compromising patient safety. Its potential effect on societal costs remains underexplored. Methods: this was a pragmatic, open-label, multi-center clinical trial powered for non-inferiority. Patients with complex appendicitis, age greater than or equal to 8 years, were randomly allocated to 2 days or 5 days of intravenous antibiotics after appendectomy. Patient inclusion lasted from June 2017 to June 2021 in 15 Dutch hospitals. The final follow-up was on September 1, 2021. The primary trial endpoint was a composite endpoint of infectious complications and mortality within 90 days. In the present study, the main outcome measures were overall societal costs, comprising direct health care costs and costs related to productivity loss, and cost-effectiveness. Direct health care costs were recorded based on data in the electronic patient files, complemented by a telephone follow-up at 90 days. In addition, data on loss of productivity were acquired through the validated productivity cost questionnaire at 4 weeks after surgery. Cost estimates were based on prices for the year 2019. Results: in total, 1,005 patients were evaluated in the intention to treat analysis, 502 patients were allocated to the 2-day group and 503 to the 5-day group. The mean difference in overall societal costs was €625, 95% C, €958 to €278 to the advantage of the 2-day group. This difference was largely explained by reduced hospital stay. Productivity losses were similar between the study groups. Restricting postoperative antibiotics to 2 days was cost-effective, with estimated cost savings of €31,117 per additional infectious complication. Conclusions: 2 days of postoperative antibiotics for complex appendicitis results in a statistically significant and relevant cost reduction, as compared with 5 days. Findings apply to laparoscopic appendectomy in a well-resourced healthcare setting. Next article is from Journal of American Medical Association Surgery. Plastic wound protector versus surgical gauze for surgical site infection reduction in open GI surgery. A randomized clinical trial. Important surgical site infections, SSIs, are prevalent hospital-acquired infections with significant patient impacts and global healthcare burdens. The World Health Organization recommends using wound protector devices in abdominal surgery as a preventive measure to lower the risk of SSIs despite limited evidence. Objective: to examine the efficacy of a dual-ring, plastic wound protector in lowering the SSI rate in open gastrointestinal, GI, surgery irrespective of intra-abdominal contamination levels. Design, setting, and participants. This multi-center, patient-blinded, parallel-arm randomized clinical trial was conducted from August 2017 to October 2022 at 13 hospitals in an academic setting. Patients undergoing open abdominal bowel surgery, e.g., for bowel perforation, were eligible for inclusion. Intervention patients were randomized 1-to-1 to a dual-ring, plastic wound protector to protect the incision site of the abdominal wall, experimental group, or a conventional surgical gauze, control group. Main outcomes and measures. The primary endpoint was the rate of SSI within 30 days of open GI surgery. Results: a total of 458 patients were randomized. After one was excluded from the control group, 457 were included in the intention to treat analysis. Mean SD, age, 58.4, 12.1 years, 256, 56.0%, male, 341, 74.6%, with a clean contaminated wound, 229 in the wound protector group and 228 in the surgical gauze group. The overall SSI rate in the intention to treat analysis was 15.7%, 72 of 458 patients. The SSI rate for the wound protector was 10.9%, 25 of 229 patients, compared with 20.5%, 47 of 229 patients, with surgical gauze. The wound protector significantly reduced the risk of SSI with a relative risk reduction, RRR, of 46.81%, 95% C, 16.64% to 66.06%. The wound protector significantly decreased the SSI rate for clean contaminated wounds, RRR, 43.75%, 95% C, 3.75% to 67.13%, particularly for superficial SSIs, RRR, 42.50%, 95% C, 7.16% to 64.39%. Length of hospital stay was similar in both groups, mean SD, 15.2, 10.5, versus 15.3, 10.2 days, as were the overall postoperative complication rates, 20.1% versus 18.8%. Conclusions and relevance. This randomized clinical trial found a significant reduction in SSI rates when a plastic wound protector was used during open GI surgery compared with surgical gaze, supporting the World Health Organization recommendation for use of wound protector devices in abdominal surgery. Next, we will be discussing articles from British Journal of Surgery. Cachexia Index for Prognostication in Surgical Patients with Locally Advanced Esophageal or Gastric Cancer, Multicenter Cohort Study. Background. Features of cancer. Cachexia adversely influence patient outcomes, yet few currently inform clinical decision-making. This study assessed the value of the Cachexia Index, CXI, a novel prognostic marker, in patients for whom neoadjuvant chemotherapy and surgery for esophagogastric cancer is planned. Methods. Consecutive patients newly diagnosed with locally advanced, T3-4 or at least N1, esophagogastric cancer between January 1, 2010 and December 31, 2015 were identified through the West of Scotland and South East Scotland cancer networks. CXI was calculated as L3 skeletal muscle index times serum albumin, neutrophil lymphocyte ratio. Sex stratified cutoff values were determined based on the area under the curve, AUC, and patients were divided into groups with low or normal CXI. Primary outcomes were disease progression during neoadjuvant chemoctherapy and overall survival, at least 5 years of follow-up. Results. Overall, 385 patients, 72% men, median age 66 years, were treated with neoadjuvant chemotherapy for esophageal, 274, or gastric, 111, cancer across the study interval. Although patients with a low CXI, men, CXI below 52, AUC 0.707, women, CXI below 41, AUC 0.759, were older with more comorbidity, disease characteristics were comparable to those in patients with a normal CXI. Rates of disease progression during neoadjuvant chemotherapy, leading to inoperability, were higher in patients with a low CXI, 28 versus 12%, adjusted or 3.07, 95% CI 1.67 to 5.64, p less than 0.001. Low CXI was associated with worsened postoperative mortality, p equals 0.019, and decreased overall survival, median 14.9 versus 56.9 months, adjusted HR 1.85, 1.42 to 2.42, p less than 0.001. Conclusion. CXI is associated with disease progression, worse postoperative mortality, and overall survival, and could improve prognostication and decision-making in patients with locally advanced esophagogastric cancer. Next we will be discussing articles from Journal of Vascular Surgery. Socioeconomic factors predict successful supervised exercise therapy completion. Objective. Supervised exercise therapy, SET, for patients with intermittent claudication, IC, can lower the risk of progression to chronic limb-threatening ischemia and amputation, while preserving and restoring functional status. Despite supporting evidence, it remains underutilized, and among those who initiate programs, attrition rates are extremely high. We hypothesize that socioeconomic factors may represent significant barriers to SET completion. Methods: patients with IC referred to SET at a multi-hospital, single-institution health care system, 2018 to 2022, from a prospectively maintained database were retrospectively analyzed. Our primary endpoint was SET program completion and graduation, defined as completion of 36 sessions. Our secondary endpoints were vascular intervention within 1 year of referral and change in ankle brachial index, ABI. Baseline demographics were assessed using standard statistical methods. Predictors of SET graduation were analyzed using multivariable logistic regression generating adjusted odds ratios, AORs, with 95% confidence intervals, Cs. Change in ABI was analyzed using t-test between subgroups. Reasons for attrition were tabulated. Patient Health Questionnaire 9, PHQ 9, Metabolic Equivalent Level, Vascular Call, Duke Activity Status, and ABI were analyzed using paired t-tests across the entire cohort. Results: 52 patients met inclusion criteria, mean age 67.85 plus or minus 10.69 years, 19 females, 36.54%, mean baseline ABI of 0.77 plus or minus 0.16. The co-pays for 100% of patients were fully covered by primary and secondary insurance plans. 21 patients, 40.38%, completed SET. On multivariable analysis, residents in a zip code with median household income less than $47,000, AOR, 0.10, 95% C, 0.01 to 0.76, P equals 0.03, and higher body mass index, AOR, 0.81, 95% C, 0.67 to 0.99, P equals 0.04, were significant barriers to SET graduation. There were no differences in ABI change or vascular intervention within 1 year between graduates and non-graduates. Non-graduates reported transportation challenges, 25.00%, lack of motivation, 20.83%, and illness/functional limitation, 20.83%, as primary reasons for SET attrition. Metabolic equivalent level, P less than or equal to 0.01, and Duke activity status scores, P equals 0.04, were significantly greater after participating in a SET program. Conclusions: although SET participation improves lower extremity and functionality outcomes, only 40% of referred patients completed therapy in our cohort. Our findings suggest that both socioeconomic and functional factors influence the odds of completing SET programs, indicating a need for holistic pre-referral assessment to facilitate enhanced program accessibility for these populations. Frailty screening for determination of hemodialysis access placement. Objective: choosing the right hemodialysis vascular access for frail patients remains difficult because the patient's preferences and the likelihood of access function and survival must be considered. We hypothesize that patients identified before arteriovenous AV access as frail by the PRISMA-7 score may have worse outcomes, indicating that fistula creation may not be the most clinically beneficial option, and it would be in the best interest of the patient to receive either AV graft, average, placement or dialysis through a percutaneous catheter. Our pilot study aims to determine whether an association exists between patient frailty as defined by PRISMA-7 and newly created AV fistula, AVF, and average access outcomes. Methods: this was a single institutional prospective cohort study of patients undergoing new AVF or average intervention from April 2021 to May 2023. Patients were assessed using the PRISMA-7 frailty questionnaire before their AV access surgery. Results: a total of 40 patients undergoing new AV access placement were investigated, among whom 53% were designated as frail, PRISMA-7 score greater than or equal to 3. When comparing the frail and non-frail new AV access groups, the access, AVF and average combined, failed in 48%, 1021, of the frail patients, but only failed in 5%, 119, of the non-frail patients 1, p equals 0.012. When distinguishing between AV access types, AVF creations follow the overall trend with 60% of AVF access, 915, sites in frail patients failing to mature when compared with non-frail patients, who all had fistulas that matured to use, p equals 0.049. Surgical site infection was absent in all frail patients and present in 5% of non-frail patients, 119. Both 30-day and 60-day readmission rates were higher in the frail group compared with the non-frail group. There was 180-day mortality present in 5 of frail patients %, 121, and absent in non-frail patients. Multivariable analysis revealed that both frailty, adjusted odd ratio, 10.19, 95% confidence interval, 1.20 to 82.25, p equals 0.033, and younger age, adjusted odd ratio, 0.953, 95% confidence interval, 0.923 to 0.983, p equals 0.002, both had a significant association with non-maturation. Power analysis revealed a power statistic of 0.898, indicating a probability of type 2 error of 10.02% with a p-value of 0.002. Hosmer-Lemshow goodness of fit for the logistic regression had 75% overall accuracy for the model. Conclusions. Patient frailty is significantly associated with an increased incidence of AV access failure to mature. Short-term mortality and revisions to promote maturation after arteriovenous fistula creation. Objective. Arteriovenous fistula, AVF, for hemodialysis access is traditionally considered superior to grafts due to infection resistance and purported improved patency. However, challenges to AVF maturation and limited patient survival may reduce AVF benefits. The objective of this study is to identify factors associated with risk of AVF requiring revision before maturation and/or mortality within 2 years of creation. Methods. We performed a retrospective review of 250 AVFs created between May 2017 and November 2020 at a single institution. Maturation was defined as the date the surgeon deemed the AVF ready for use or the patient successfully used the AVF for dialysis. The risk analysis index was used to calculate frailty. The primary outcome was a composite of endovascular/surgical revision to promote maturation and/or mortality within 2 years of AVF creation, REVDED. Results. Survival at 2 years after AVF creation was 82% and 22% patients underwent AVF revision. Of those, 59% patients progressed to AVF maturation. Of the 250 AVFs, 36% met the primary outcome of REVDED and 64% did not, NORVDED. There was no difference between the REVDED and NORVDED groups in age, p equals 0.18, sex, p equals 0.75, white race, p equals 0.97, Hispanic ethnicity, p equals 0.62, obesity, p equals 0.76, coronary artery disease, p equals 0.07, congestive heart failure, p equals 0.29, diabetes mellitus, p equals 0.78, chronic obstructive pulmonary disease, p equals 0.10, dialysis status, p equals 0.63, hypertension, p equals 0.32, peripheral arterial disease, p equals 0.34, or dysrhythmia, p equals 0.13. There was no difference between the groups in the forearm versus the upper arm location of AVF, p equals 0.42, or the vein diameter, p equals 0.58. Forearm access, as opposed to upper arm AVF creation, was associated with higher rate of revision before maturation, p equals 0.05. More patients in REVDED were frail or very frail, 60% versus 48%, p equals 0.05. Of the AVFs that matured, maturation required longer time in REVDED, 110.0 plus or minus 9.1 days versus 78.8 plus or minus 5.6 days, mean plus or minus standard deviation, p equals 0.003. Adjusted for the vein diameter and the forearm versus the upper arm, frailty increased the odds of REVDED by 1.9, 95% confidence interval, 1.1, 3.3. Conclusions. Frail patients who underwent AVF were significantly more likely to die within 2 years of AVF creation, with no significant association between frailty and the need for revisions to promote maturation. Forearm AVFs were more likely to require revisions. In patients who are frail, with a high likelihood of 2-year mortality, graft may be more appropriate than AVF. If AVF is being considered in a frail patient, upper arm AVFs should be prioritized over forearm AVFs. Characterization of long-term survival in Medicare patients undergoing arteriovenous hemodialysis access. Background: patients undergoing arteriovenous (AV) access creation for hemodialysis often have significant comorbidities. Our goal was to quantify the long-term survival and associated risk factors for long-term mortality in these patients to aid in optimization of goals and expectations. Methods: the Vascular Implant Surveillance and Interventional Outcomes Network Vascular Quality Initiative Medicare-linked data was used to assess long-term survival in the HD registry. Demographics, comorbidities, and interventions were recorded. Because the majority of hemodialysis patients are provided Medicare, Medicare linkage was used to obtain survival data. Multivariable analysis was used to identify independent associations with mortality. Results: there were 13,945 AV access patients analyzed, including 10,872, 78%, AV fistulas, and 3,073, 22%, AV grafts. The median age was 67 years and 56% of patients were male. Approximately one-third had a prior AV access and 44.7% had prior tunneled dialysis catheters. Patients receiving an AV fistula, compared with AV grafts, were more often younger, male, white, obese, independently ambulatory, preoperatively living at home, and less often have a prior AV access and tunneled dialysis catheters, p less than 0.05 for all. The 5-year mortality overall was 62.9%, with 61.2% for AV fistulas and 68.8% for AV grafts, p less than 0.001. On multivariable analysis for 5-year mortality, non-ambulatory status, hazard ratio, HR, 1.67, 95% confidence interval, C, 1.53 to 1.83, p less than 0.001, lower extremity access, HR, 1.67, 95% C, 1.35 to 2.05, p less than 0.001, human immunodeficiency virus or acquired immunodeficiency syndrome, HR, 1.44, 95% C, 1.13 to 1.82, p less than 0.001, white race, HR, 1.43, 95% C, 1.35 to 1.51, p less than 0.001, congestive heart failure, HR, 1.33, 95% C, 1.26 to 1.41, p less than 0.001, chronic obstructive pulmonary disease, HR, 1.23, 95% C, 1.15 to 1.31, p less than 0.001, and AV graft placement, HR, 1.12, 95% C, 1.02 to 1.23, p equals 0.016, were most associated with poor survival. Factors associated with improved survival were never smoking, HR, 0.73, 95% C, 0.67 to 0.79, p less than 0.001, prior/quit smoking, HR, 0.78, 95% C, 0.72 to 0.84, p less than 0.001, preoperative home living, HR, 0.75, 95% C, 0.68 to 0.83, p less than 0.001, and hypertension, HR, 0.89, 95% C, 0.8 to 0.99, p equals 0.03. Conclusions: long-term survival in Medicare patients undergoing AV access creation is poor, with nearly 2/3 of patients having died at 5 years. There are many modifiable risk factors that may improve survival in these patients and give an opportunity for transplantation. Multicenter parallel randomized trial evaluating incisional negative pressure wound therapy for the prevention of surgical site infection after lower extremity bypass. Objective: incisional negative pressure wound therapy, input, applied over all incisions after lower extremity bypass and the prevention of surgical site infections, SSIs, is unclear. The primary and secondary aims of this study were to investigate if prophylactic input after the elective lower extremity bypass prevents SSI and other surgical wound complications. Methods: this was a multicenter, parallel, randomized controlled trial. Patients undergoing elective lower extremity bypass in 3 hospitals were randomized to either input or standard dressings. SSIs or other wound complications were assessed within the first 90 days by wound care professionals blinded to the randomized result. The validated additional treatment, serous discharge, erythema, purulent exudate, separation of deep tissues, isolation of bacteria, and stay, asepsis, score was used to objectively assess the wounds. A sepsis score greater than or equal to 21 is defined as an SSI. Unilateral and bilateral groups were analyzed with the Fisher-Exact test and the McNamara test, respectively. Results: in the unilateral group, N equals 100, the incidence of SSI in the input group was 34.9%, 1543, compared with 40.3%, 2357, in the control group, according to the asepsis score, P equals 0.678. In the bilateral group, N equals 7, the SSI rate was 14.3%, 1/7, in the input group compared with 14.3%, 1/7, in the control group, P equals 1.00. In the unilateral group, there was a higher wound dehiscence rate in the control group, 43.9%, compared with the input group, 23.3%, P equals 0.0366. No serious input-related adverse events were recorded. Conclusions: there was no reduction of SSI rates in leg incisions with input compared with standard dressings in patients undergoing elective lower extremity bypass, whereas input reduced the incidence of wound dehiscence. Cryopreserved arterial allografts versus autologous vein for arterial reconstruction in infected fields. Objective: peripheral arterial infections are rare and difficult to treat when an in situ reconstruction is required. Autologous vein, AV, is the conduit of choice in many scenarios. However, cryopreserved arterial allografts, CAAs, are an alternative. We aim to assess our experience with CAAs and AVs for reconstruction in primary and secondary peripheral arterial infections. Methods: data from patients with peripheral arterial infections undergoing reconstruction with CAA or AV from January 2002 through August 2022 were retrospectively analyzed. Patients with aortic or iliac-based infections were excluded. Results: a total of 42 patients, 28 CAA, 14 AV, with a mean age of 65 and 69 years, respectively, were identified. Infections were secondary in 31 patients, 74%, and primary in 11, 26%. Secondary infections included 10 femoral grafts, 10 femoropopliteal or femoral distal grafts, 5 femoral patches, 4 carotid subclavian grafts, 1 carotid graft, and 1 infected carotid patch. Primary infection locations included 6 femoral, 3 popliteal, and 2 subclavian arteries. In patients with lower extremity infections, associated groin infections were present in 19, 56%. Preoperative blood cultures were positive in 17 patients, 41%. AVs included saphenous vein in 8 and femoral vein in 6. Intraoperative cultures were negative in 9 patients, 23%, polymicrobial in 8, 21%, and monomicrobial in 22, 56%. 30-day mortality occurred in 4 patients, 10%, 2 due to multisystem organ failure, 1 due to graft rupture causing acute blood loss and myocardial infarction, and 1 due to an unknown cause post-discharge. Median follow-up was 20 months and 46 months in the CAA and AV group, respectively. Graft-related reintervention was performed in 6 patients in the CAA group, 21%, and 1 patient in the AV group, 7%. Freedom from graft-related reintervention rates at 3 years were 82% and 92% in the CAA and AV group, respectively, p equals 0.12. Survival rates at 1 and 3 years were 85% and 65% in the CAA group, and 92% and 84% in the AV group, p equals 0.13. Freedom from loss of primary patency was similar with 3-year rates of 77% and 83% in the CAA and AV group, respectively, p equals 0.25. No patients in either group were diagnosed with reinfection. Conclusions. CAAs are an alternative conduit for peripheral arterial reconstructions when AV is not available. Although there was a trend towards higher graft-related reintervention rates in the CAA group, patency is similar and reinfection is rare. Next article is from Surgical Endoscopy. The association between microvascular and macrovascular diseases and diabetes remission after bariatric surgery. Background. Type 2 diabetes mellitus, T2DM, results in detrimental vascular complications including both microvascular and macrovascular diseases. Roux-en-Y gastric bypass, RYGB, and sleeve gastrectomy, SG, are effective weight loss therapies that enhance T2DM remission. However, limited data are present regarding the association between diabetes-associated diseases before RYGB and SG with T2DM remission. Methods. This is a retrospective cohort study in patients with T2DM who underwent RYGB or SG. We collected data on preoperative microvascular, i.e., retinopathy, nephropathy, and neuropathy, and macrovascular, coronary artery disease, cerebrovascular accidents, and peripheral artery disease, diabetes-associated diseases. Our endpoints included assessment of association and cumulative effect of diabetes-associated diseases and disease remission. We also performed a multivariate logistic regression to evaluate the parameters associated with T2DM remission. Results. A total of 536 patients, 67% female, 94% white, were included in this study. Patients without diabetes-associated diseases had an OR of 2.72, 95% C 1.92 to 3.88, to achieve T2DM remission compared to patients with diabetes-associated diseases, 27.9% versus 59.4%, p less than 0.001. Importantly, there was an additive effect of the number of diabetes-associated diseases on the T2DM remission, p less than 0.001. We demonstrate a significant association between HbA1c, p less than 0.001, number of diabetes medications, p less than 0.001, T2DM duration, p less than 0.001, surgery type, p equals 0.009, and insulin use, p equals 0.04, with T2DM remission. Conclusion. Patients with presurgical diabetes-associated diseases had a lower remission rate after RYGB and SG. Not only do these complications represent a more practical and consistent variable to predict T2DM remission, but also help planning a multidisciplinary management of patients with more severe T2DM. Regional anesthesia for postoperative pain management following laparoscopic, visceral, non-oncological surgery, a systematic review and meta-analysis. Background. Postoperative pain management following laparoscopic, non-oncological visceral surgery in adults is challenging. Regional anesthesia could be a promising component in multimodal pain management. Methods. We performed a systematic review and meta-analysis with grade assessment. Primary outcomes were postoperative acute pain intensity at rest/during movement after 24 hours, the number of patients with block-related adverse events, and the number of patients with postoperative paralytic ileus. Results. 82 trials were included. Peripheral regional anesthesia combined with general anesthesia versus general anesthesia may result in a slight reduction of pain intensity at rest at 24 hours, mean difference, MD, minus 0.72 points. 95% confidence interval, C, minus 0.91 to minus 0.54, I2 equals 97%, low certainty evidence, which was not clinically relevant. The evidence is very uncertain regarding the effect on pain intensity during activity at 24 hours, MD -0.8 points, 95% C -1.17 to -0.42, I2 equals 99%, very low certainty evidence, and on the incidence of block-related adverse events. In contrast, neuraxial regional analgesia combined with general anesthesia versus general anesthesia may reduce postoperative pain intensity at rest in a clinical relevant matter, MD -1.19 points, 95% C -1.99 to -0.39, I2 equals 97%, low certainty evidence, but the effect is uncertain during activity, MD -1.13 points, 95% C -2.31 to 0.06, I2 equals 95%, very low certainty evidence. There is uncertain evidence that neuraxial regional analgesia combined with general anesthesia versus general anesthesia increases the risk for block-related adverse events, relative risk, RR, 5.11, 95% C 1.13 to 23.03, I2 equals 0%, very low certainty evidence. Conclusion. This meta-analysis confirms that regional anesthesia might be an important part of multimodal postoperative analgesia in laparoscopic visceral surgery, for example in patients at risk for severe postoperative pain, and with large differences between surgical procedures and settings. Further research is required to evaluate the use of adjuvants and the additional benefit of regional anesthesia in ERAS programs. Quality indicators for ambulatory colectomy, literature search and expert consensus. Background. Care for patients undergoing elective colectomy has become increasingly standardized using enhanced recovery programs, ERP. ERP, incorporating minimally invasive surgery, MIS, decreased postoperative morbidity and length of stay, LOS. However, disruptive changes are needed to safely introduce colectomy in an ambulatory or same-day discharge, SDD, setting. Few research groups show the feasibility of ambulatory colectomy. So far, no minimum standards for the quality of care of this procedure have been defined. This study aims to identify quality indicators, QIs, that assess the quality of care for ambulatory colectomy. Methods. A literature search was performed to identify recommendations for ambulatory colectomy. Based on that search, a set of QIs was identified and categorized into 7 domains: preparation of the patient, pre-admission, anesthesia, surgery, in-hospital monitoring, home monitoring, feasibility, and clinical outcomes. This list was presented to a panel of international experts, surgeons and anesthesiologists, in a one-round Delphi to assess the relevance of the proposed indicators. Results. Based on the literature search, 2010 to 2021, 3,841 results were screened on title and abstract for relevant information. 9 papers were withheld to identify the first set of QIs, N equals 155. After excluding duplicates and outdated QIs, this long list was narrowed down to 88 indicators. Afterward, consensus was reached in a one-round Delphi on a final list of 32 QIs, aiming to be a comprehensive set to evaluate the quality of ambulatory colectomy care. Conclusion. We propose a list of 32 QI to guide and evaluate the implementation of ambulatory colectomy. Next article is from Annals of Surgical Oncology. Early versus late drainage removal in patients who underwent pancreatic duodenectomy, a comprehensive systematic review and meta-analysis of randomized controlled trials using trial sequential analysis. Background. The superiority of early drain removal, EDR, versus late, LDR, after pancreatic duodenectomy, PD, has been demonstrated only in RCTs. Methods. A meta-analysis was conducted using a random effects model and trial sequential analysis. The critical endpoints were morbidity, redrainage, relaparotomy, and postoperative pancreatic fistula, CR-POP. Hemorrhage, PPH, delayed gastric emptying, DG, length of stay, LOS, and readmission rates were also evaluated. Risk ratios, RRs, and mean differences, MDs, with a 95% confidence interval, C, were calculated. Type I and Type II errors were excluded, comparing the accrued sample size, ASS, with the required sample size, RIS. When RIS is superior to AS, type 1 or 2 errors can be hypothesized. Results: AS was 632 for all endpoints except DGE and PPH, 557 patients. The major morbidity, RR 0.55, 95% C 0.32 to 0.97, was lower in the EDR group. The CR-POP rate was lower in the EDR than in the LDR group, RR 0.50, but this difference is not statistically significant, 95% C 0.24 to 1.03. The RIS to confirm or exclude these results can be reached by randomizing 5,959 patients. The need for percutaneous drainage, relaparotomy, PPH, DGE, and readmission rates was similar. The related RISs were higher than AS, and type 2 errors cannot be excluded. Loss was shorter in the EDR than the LDR group, MD-2.25, 95% C-3.23 to -1.28. The RIS was 567, and type I errors can be excluded. Conclusions: EDR, compared with LDR, is associated with lower major morbidity and shorter loss. Comparison of octreotide and vasopressors as first-line treatment for intraoperative carcinoid crisis. Background: intraoperative carcinoid crisis is typically sudden onset of profound hypotension during operations on patients with neuroendocrine tumors. The crisis was thought to be due to massive release of hormones, and perioperative octreotide was recommended as a prophylaxis against the crisis and as first-line treatment. Recent studies show that octreotide does not prevent the crisis and that no massive release of hormones occurs. Therefore, the authors hypothesized that octreotide is not effective for treating the crisis. Methods: a prospective carcinoid anesthesia database was analyzed for occurrences of crisis. Outcomes were compared between protocols when first-line therapy was bolus octreotide and when it was vasopressors without octreotide. Significance was determined by students' t-test, the Mann-Whitney U test, and Fisher's exact test. Results: among operations performed with octreotide as first-line treatment, N equals 150, crisis occurred for 45-30% patients. The median crisis duration was 6 minutes, 27% patients had crises longer than 10 minutes, 42 patients, 93%, required subsequent vasopressor administration to resolve the crisis, and 2% operations were aborted. Among operations performed with vasopressors as the first-line treatment, N equals 195, crisis occurred for 25% patients, P equals 0.31, the median crisis duration was 3 minutes, P less than 0.001, and no crisis lasted longer than 10 minutes, P equals 0.001. Patients treated with vasopressors were less likely to have multiple crises and had a shorter total time in crisis, a shorter anesthesia time, and no aborted operations, P less than 0.05 for all. Conclusions: first-line octreotide was ineffective treatment for carcinoid crisis, with patients requiring vasopressors to resolve the crisis, and many crises lasting longer than 10 minutes. First-line vasopressor treatment resulted in significantly shorter crisis durations, fewer crises and aborted operations, and shorter anesthesia times. Vasopressors should be used as first-line treatment for intraoperative crisis, and treatment guidelines should be changed. Long-term outcome of proximal gastrectomy for upper third advanced gastric and Seward type 2 esophagogastric junction cancer compared with total gastrectomy, a propensity score matched analysis. Background: this study aimed to investigate the oncologic long-term safety of proximal gastrectomy for upper third advanced gastric cancer, AGC, and Seward type 2 esophagogastric junction, EGJ, cancer. Methods: the study enrolled patients who underwent proximal gastrectomy, PG, or total gastrectomy, TG, with standard lymph node, lane, dissection for pathologically proven upper third AGC and EGJ cancers between January 2007 and December 2018. Propensity score matching with a 1-to-1 ratio was performed to reduce the influence of confounding variables such as age, sex, tumor size, T stage, end stage, and tumor node metastasis, TNM, stage. Kaplan-Meier survival analysis was performed to analyze oncologic outcome. The prognostic factors of recurrence-free survival, RFS, were analyzed using the Cox proportional hazard analysis. Results: of the 713 enrolled patients in this study, 60 received PG and 653 received TG. Propensity score matching yielded 60 patients for each group. The overall survival rates were 61.7% in the PG group and 68.3% in the TG group, p equals 0.676. The RFS was 86.7% in the PG group and 83.3% in the TG group, p equals 0.634. The PG group showed 8 recurrences, 1 anastomosis site, 1 para-aortic lane, 1 liver, 1 spleen, 1 lung, 1 splenic hilar lane, and 2 remnant stomachs. In the multivariate analysis, the operation method was not identified as a prognostic factor of tumor recurrence. Conclusion: the patients who underwent PG had a long-term oncologic outcome similar to that for the patients who underwent TG for upper third AGC and EGJ cancer. Laparoscopic left hepatectomy for intrahepatic cholangiocarcinoma. Background: minimally invasive surgery for intrahepatic cholangiocarcinoma, ICC, remains challenging, especially in advanced patients. Patient and method: a 66-year-old male was diagnosed with stage 2 ICC after a comprehensive evaluation and was scheduled for laparoscopic exploration and left hepatectomy. Results: the pure laparoscopic left hepatectomy was completed in 240 minutes, employing a no-touch-on-block technique and lymphadenectomy skeletonization. The patient was discharged 6 days after the operation without any complications and received gemcitabine and cisplatin treatment postoperatively. There was no recurrence during 14 months of follow-up. Conclusions: our experience demonstrates that when utilizing the no-touch-on-block technique, standardized lymphadenectomy through skeletonization, and effective control of bleeding, surgeons with extensive expertise in laparoscopic hepatectomy can achieve results comparable to open surgery. Next article is from Journal of the American College of Surgeons, April 2024, Volume 238, Issue 4. Artificial Intelligence to Predict Quality of Life Outcomes for Vascular Intervention of the Leg. Background: artificial intelligence, AI, tools created to enhance decision-making may have a significant impact on treatment algorithms for peripheral arterial disease, PAD. A Markov-based AI model was developed to predict optimal therapy based on maximization of calculated quality of life, CQAL, a patient-centered system of assessment designed to report outcomes directly linked to health-related quality of life. Study design: the AI model was prospectively interrogated immediately after individual interventions for PAD over a 12-year period to test predictive performance. Patient CQAL was determined at each patient follow-up visit. Results: a total of 1,143 consecutive patients were evaluated, with a median follow-up of 18 months. Observed mean annualized CQAL was higher than predicted by the model, 0.85 plus or minus 0.38 versus 0.79 plus or minus 0.18, p less than 0.0001. Of 5 potential clinical outcomes, the AI model correctly predicted final status in 71.3% of patients, with insignificant model performance deterioration over time, minus 0.15% per month, R equals minus 0.49, P equals 0.063. The chance of having the condition predicted by the model was 0.57 plus or minus 0.32, compared with a theoretical maximum of 0.70 plus or minus 0.19, P less than 0.0001, mean ratio 0.79. The AI model performed better in patients with claudication than limb-threatening ischemia, 75.5% versus 63.6%, p equals 0.014, but equally well for open or endovascular intervention, 69.8% versus 70.5%, p equals 0.70. Graft or artery patency and amputation-free survival were better for patients with claudication and those treated with endovascular techniques. Conclusions: AI can successfully predict treatment for PAD that maximizes patient quality of life in most cases. Future application of AI incorporating better estimates of patient anatomic and physiological risk factors and refinement of model structure should further enhance performance. The kidney not taken, single kidney use in deceased donors. Background: the non-use rate for kidneys recovered from deceased donors is increasing, rising to 27% in 2023. In 10% of these cases, one kidney is transplanted but the mate kidney is not. Study design: we conducted a retrospective, single-center cohort study from December 2001 to May 2023 comparing single kidneys transplanted at our center, where the contralateral kidney was not used, to kidneys where both were transplanted separately, at least one of which was at our center. Results: we performed 395 single deceased donor kidney transplants in which the mate kidney was not transplanted. Primary reasons for mate kidney non-use were as follows: no recipient located or list exhausted, 33.4%, kidney trauma or injury or anatomic abnormalities, 18.7%, biopsy findings, 16.7%, and poor renal function, 13.7%. Mean donor and recipient ages were 51.5 plus or minus 14.2 and 60 plus or minus 12.6 years, respectively. Mean kidney donor profile index was 73% plus or minus 22%, and 104 donors, 26.3%, had kidney donor profile index greater than 85%. Mean cold ischemia was 25.6 plus or minus 7.4 hours, and 280 kidneys, 70.7%, were imported. Compared with 2,303 concurrent controlled transplants performed at our center, primary nonfunction or thrombosis, 5.1% single versus 2.8% control, and delayed graft function, 35.4% single versus 30.1% control, were greater with single kidney use, both p less than 0.05. Median patient and death-censored graft survival were shorter in the single group, 11.6 versus 13.5 years, p equals 0.03 and 11.6 versus 19 years, p equals 0.003, although the former was at least double median survival on the waiting list. In patients with functioning grafts in the single kidney group, 1-year mean serum creatinine was 1.77 plus or minus 0.8 mg/dl and estimated glomerular filtration rate was 44.8 plus or minus 20 milliliter per minute /1.73 meters 2. Conclusions: these findings suggest that many mate kidneys are being inappropriately rejected, given the acceptable outcomes that can be achieved by transplanting the single kidney in appropriately selected recipients. Early cholecystectomy in patients with sickle cell disease with uncomplicated cholelithiasis is associated with better outcomes. Background: up to 85% of patients with sickle cell disease, SCD, will develop gallstones by their third decade. Cholecystectomy is the most commonly performed procedure in these patients. Cholecystectomy is recommended for patients with SCD with symptomatic cholelithiasis and leads to lower morbidity. No contemporary large studies have evaluated this recommendation or associated clinical outcomes. This study evaluates clinical outcomes after cholecystectomy in patients with SCD and cholelithiasis with specific advanced clinical presentations. Study design: the nationwide inpatient sample was queried for patients with SCD and gallbladder disease between 2006 and 2015. Patients were divided into groups based on their disease presentation, including uncomplicated cholelithiasis, acute and chronic cholecystitis, and gallstone pancreatitis. Clinical outcomes associated with disease presentation were analyzed. Statistical analysis was performed using the student's t-test, chi-square test, ANOVA, and logistic regression. Results: there were 6,662 patients with SCD who presented with cholelithiasis. Median age was 20, interquartile range 16 to 34 years, and 54% were female patients. Cholecystectomy was performed in 1,779 patients with SCD, with the most common indication being chronic cholecystitis, 44%, followed by uncomplicated cholelithiasis, 27%, acute cholecystitis, 21%, and cholecystolithiasis or gallstone pancreatitis, 8%. On multivariable regression, advanced clinical presentation was the strongest predictor of perioperative vaso-occlusive crisis, which was the most common complication. Patients undergoing cholecystectomy for uncomplicated cholecystolithiasis were at lower risk than those with acute cholecystitis, odds ratio or 2.37, 95% C 1.64 to 3.41, chronic cholecystitis, or 1.74, 95% C 1.26 to 2.4, and cholecystolithiasis or gallstone pancreatitis, or 2.24, 95% C 1.41 to 3.57. Conclusions. 73% of patients with SCD have advanced clinical presentation at the time of their cholecystectomy. After cholecystectomy, perioperative vaso-occlusive events were significantly increased in patients with advanced clinical presentation. These data support screening abdominal ultrasounds and early cholecystectomy for cholecystolithiasis in patients with surrogate perception of disability after hospitalization for traumatic brain injury. Background. The Glasgow Outcome Scale Extended, GOSE, is a measure of recovery after traumatic brain injury, TBI. Public surveys rate some Gauze states as worse than death. Direct family experience caring for patients with TBI may impact views of post-TBI disability. Study design. We conducted a national cross-sectional computer adaptive survey of surrogates of TBI dependents incurring injury more than 1 year earlier. Using a standard Gamble approach in randomized order, surrogates evaluated preferences for post-TBI Gauze states from Gauze 2, bedridden, unaware, to Gauze 8, good recovery. We calculated median, interquartile range, IQR, health utilities for each post-TBI state, ranging from -1 to 1, with 0 as reference, death equals Gauze 1, and assess socio-demographic associations using proportional odds logistic regression modeling. Results. Of 515 eligible surrogates, 298, 58%, completed scenarios. Surrogates were median aged 46, IQR 35 to 60, 54% married, with Santa Clara strength of faith 14, 10 to 18. TBI dependents had a median Gauze 5, 3 to 7. Median, IQR, health utility ratings for Gauze 2, Gauze 3, and Gauze 4 were -0.06, -0.50 to -0.01, -0.01, -0.30 to 0.45, and 0.30, -0.01 to 0.80, rated worse than death by 91%, 65%, and 40%, respectively. Surrogates rated Gauze 4, daily partial help, worse than the general population. Married surrogates rated Gauze 4 higher, p less than 0.01. Higher strength of faith was associated with higher utility scores across Gauze states, p equals 0.034. Conclusions. In this index study of surrogate perceptions about disability after TBI, poor neurologic outcomes, vegetative, needing all-day or partial daily assistance, were perceived as worse than death by at least 1 in 3 surrogates. Surrogate perceptions differed from the unexposed public. Long-term perceptions about post-TBI disability may inform earlier, tailored shared decision-making after neurotrauma. Empiric cryoprecipitate transfusion in patients with severe hemorrhage, results from the U.S. experience in the International Cryostat 2 trial. Background. Hypofibrinogenemia has been shown to predict massive transfusion, and is associated with higher mortality in severely injured patients. However, the role of empiric fibrinogen replacement in bleeding trauma patients remains controversial. We sought to determine the effect of empiric cryoprecipitate as an adjunct to a balanced transfusion strategy, 1:1:1. Study design. This study is a sub-analysis of patients treated at the single U.S. trauma center and a multi-center randomized controlled trial. Trauma patients, more than 15 years, were eligible if they had evidence of active hemorrhage requiring emergent surgery or interventional radiology, massive transfusion protocol, MTP, activation, and received at least 1 unit of blood. Transfer patients, those with injuries incompatible with life, or those injured more than 3 hours earlier were excluded. Patients were randomized to standard MTP, standard, or MTP plus 3 pools of cryoprecipitate, CRYO. Primary outcomes included all-cause mortality at 28 days. Secondary outcomes were transfusion requirements, intraoperative and postoperative coagulation laboratory values, and quality of life measures, Glasgow Outcome Score extended. Results: 49 patients, 23 in the cryo group and 26 in the standard group, were enrolled between May 2021 and October 2021. Time to randomization was similar between groups, 14 versus 24 minutes, p equals 0.676. Median time to cryoprecipitate was 41 minutes, interquartile range 37 to 48. There were no differences in demographics, arrival physiology, laboratory values, or injury severity. Intraoperative and ICU thromboelastography values, including functional fibrinogen, were similar between groups. There was no benefit to cryo with respect to post-emergency department transfusions, intraoperative and ICU through 24 hours, complications, Glasgow Outcome Score, or mortality. Conclusions: in this study of severely injured, bleeding trauma patients, empiric cryoprecipitate did not improve survival or reduce transfusion requirements. Cryoprecipitate should continue as an on-demand addition to a balanced transfusion strategy, guided by laboratory values, and should not be given empirically. Transition to permitless open carry and association with firearm-related suicide. Background: firearm-related death rates continue to rise in the U.S. As some states enact more permissive firearm laws, we sought to assess the relationship between a change to permitless open carry, PLOC, and subsequent firearm-related death rates, a currently understudied topic. Study design: using state-level data from 2013 to 2021, we performed a linear panel analysis using a state fixed effects model. We examined total firearm-related death, suicide, and homicide rates separately. If a significant association between OC law and death rate was found, we then performed a difference in difference, DID, analysis to assess for a causal relationship between changing to PLOC and increased death rate. For significant DID results, we performed confirmatory DID separating firearm and non-firearm death rates. Results: 19 states maintained a no OC or permit required law, whereas 5 changed to permitless and 26 had a PLOC before 2013. The fixed effects model indicated more permissive OC law that was associated with increased total firearm-related deaths and suicides. In DID, changing law to PLOC had a significant average treatment effect on the treated of 1.57, 95% C 1.05 to 2.09, for total suicide rate but no significant average treatment effect for the total firearm-related death rate. Confirmatory DID results found a significant average treatment effect on the treated of 1.18, 95% C 0.90 to 1.46, for firearm suicide rate. Conclusions: OC law is associated with total firearm-related death and suicide rates. Based on our DID results, changing to PLOC is indeed strongly associated with increased suicides by Race and ethnic group enrollment and outcomes for Wilms tumor, analysis of the current era Children's Oncology Group study, RNO3B2. Background: to review race and ethnic group enrollment and outcomes for Wilms tumor, weight, across all 4 risk-assigned therapeutic trials from the current era Children's Oncology Group renal tumor biology and risk stratification protocol, RNO3B2. Study design: for patients with weight enrolled in RNO3B2, 2006 to 2019, disease and biologic features, therapeutic study-specific enrollment, and event-free, EFS and overall, OS, 4-year survival were compared between institutionally reported race and ethnic groups. Results: among 5,146 patients with weight, no statistically significant differences were detected between race and ethnic groups regarding subsequent risk-assigned therapeutic study enrollment, disease stage, histology, biologic factors, or overall EFS or OS, except the following variables: Black children were older and had larger tumors at enrollment, whereas Hispanic children had lower rates of diffuse anaplasia weight and loss of heterozygosity at 1p. The only significant difference in EFS or OS between race and ethnic groups was observed among the few children treated for diffuse anaplasia weight with regimen UH1 and -2 on high-risk protocol, RNO321. On this therapeutic arm only, Black children showed worse EFS, hazard ratio equals 3.18, and OS, hazard ratio equals 3.42. However, this finding was not replicated for patients treated with regimen UH1 and -2 under RNO3b2 but not on RNO321. Conclusions. Race and ethnic group enrollment appeared constant across RNO3b2 risk-assigned therapeutic trials. EFS and OS on these therapeutic trials when analyzed together were comparable regarding race and ethnicity. Black children may have experienced worse stage-specific survival when treated with regimen UH1 and -2 on RNO321, but this survival gap was not confirmed when analyzing additional high-risk RNO3b2 patients. Next article is from Journal of Trauma and Acute Care Surgery. Tranexamic acid is not associated with a higher rate of thrombotic-related reintervention after major vascular injury repair. Background. Tranexamic acid, TXA, is associated with lower mortality and transfusion requirements in trauma patients, but its role in thrombotic complications associated with vascular repairs remains unclear. We investigated whether TXA increases the risk of thrombosis-related technical failure, TRTF, in major vascular injuries, MVI. Methods. The PR Prospective Observational Vascular Injury Treatment, PROVE-IT, registry was queried from 2013 to 2022 for MVI repaired with an open or endovascular intervention. The relationship between TXA administration and TRTF was examined. Results. The TXA group, N equals 297, had higher rates of hypotension at admission, 33.6% versus 11.5%, p less than 0.001, need for continuous vasopressors, 41.4% versus 18.4%, p less than 0.001, and packed red blood cell transfusion, 3.2 versus 2.0 units, p less than 0.001, during the first 24 hours compared with the non-TXA group, N equals 1941, although demographics, injury pattern, and interventions were similar. Cryoprecipitate, 9.1% versus 2%, p less than 0.001, and anticoagulant administration during the intervention, 32.7% versus 43.8%, p less than 0.001, were higher in the TXA group. There was no difference in the rate of factor VII used between groups, 1% versus 0.7%, p equals 0.485. Thrombosis-related technical failure was not different between the groups, 6.3% versus 3.8, p equals 0.141, while the rate of immediate need for reoperation, 10.1% versus 5.7%, p equals 0.006, and overall reoperation, 11.4% versus 7%, p equals 0.009, was significantly higher in the TXA group on univariate analysis. There was no significant association between TXA and a higher rate of immediate need for reintervention, odds ratio, or 1.19, 95% confidence interval, c. 0.75 to 1.88, p equals 0.465, overall reoperation rate, or 1.33, 95% c. 0.82 to 2.17, p equals 0.249, and thrombotic events in a repaired vessel, or 1.07, 95% c. 0.60 to 1.92, p equals 0.806, after adjusting for type of injury, vasopressor infusions, blood product and anticoagulant administration, and hemodynamics. Conclusion. Tranexamic acid is not associated with a higher risk of thrombosis-related technical failure in traumatic injuries requiring major vascular repairs. Further prospective studies to examine dose-dependent or time-dependent associations between TXA and thrombotic events in MVIs are needed. The value of chest radiography after chest tube removal in non-ventilated trauma patients, a post-hoc analysis of a multi-center prospective cohort study. Background. Chest tubes are commonly placed in trauma care to treat life-threatening intrathoracic injuries by evacuating blood or air from the pleural cavity. Currently, it is common practice to routinely obtain chest radiographs between 1 to 8 hours after chest tube removal, while the necessity of it has been questioned. This study describes the ins and outs of chest tubes and evaluates the value of routine post-removal chest radiography in non-ventilated trauma patients. Methods: a post-hoc analysis of a multi-center observational prospective cohort study was performed in blunt chest trauma patients admitted with multiple rib fractures to 2 Level 1 trauma centers between January 2018 and March 2021, and treated with 1 or more chest tubes. Exclusion criteria were mechanical ventilation during chest tube removal, missing reports of post-removal chest radiography, transfer to another hospital, or mortality before chest tube removal. Descriptive analyses were performed to calculate the number of findings on post-removal chest radiographs and reinterventions. Results: a total of 207 patients were included for analysis, of whom 14 underwent bilateral chest tube placement, resulting in 221 chest tube removals investigated in this study. The mean plus or minus SDH was 58 plus or minus 17 years, 71% were male, 73% had American Society of Anesthesiologists scores of 1 or 2, and the median injury severity score was 19, interquartile range, 14 to 29. In 68 of 221 chest tube removals, 31%, post-removal chest radiography showed increased or recurrent intrathoracic pathology, i.e., 13% pneumothorax, 18% pleural fluid, and 8% atelectasis. Only 3% of these patients underwent a same-day reintervention based on these findings, of whom 1 had signs or symptoms of recurrent pathology and 1 was asymptomatic. Conclusion: it seems safe to omit routine use of post-removal chest radiography in non-ventilated blunt chest trauma patients, and to selectively use imaging in those patients presenting with clinical signs or symptoms after chest tube removal. Developing a National Trauma Research Action Plan, results from the Regulatory Challenges Delphi Survey. Background: in 2016, the National Academies of Sciences, Engineering, and Medicine issued a report calling for a National Trauma Research Action Plan, TRAP, requiring a resourced, coordinated, joint approach to trauma care research. The National Academies of Sciences, Engineering, and Medicine report recommended the identification of regulatory barriers to trauma research. The TRAP Regulatory Challenges panel of trauma researchers and regulatory professionals was convened to identify the most challenging aspects of regulatory processes involved in conducting research. Methods: trauma researchers and regulatory experts were recruited to identify and rate challenging regulatory issues in 2021 to 2022. Challenge statements were developed from a comprehensive scoping review. Panelists rated the challenge level for each statement on a 9-point Likert scale. The Delphi survey was conducted over 3 online rounds. Consensus was defined a priori as greater than or equal to 60% agreement. Results of the Delphi survey were presented to the panel during a webinar. Panel participants then participated in breakout sessions to strategize solutions, share lessons learned, and identify where more regulatory guidance is needed. Results: 38 subject matter experts rated 175 regulatory challenges, of which 141, 81%, reached the consensus threshold. Of the consensus-reaching challenge statements, 42 had a challenge rating of 6 or higher. Among the highest-rated challenges were issues pertaining to conducting pre-hospital research, exception from informed consent, mistrust of research among various racial and ethnic groups, and issues specific to conducting pediatric trauma research. Conclusion: this Delphi survey rated challenges called from a regulatory literature scoping review. The panel identified the most challenging aspects of human subjects protection while conducting trauma research and recommended strategies and best practices to address them. The findings from this study were used to develop the TRAP Investigator Toolkit, which is available on the Internet as a resource for trauma researchers. Next article is from the American Journal of Surgery. Kribari, does it apply in real time? An analysis of a community level 1 trauma center. Background: Major Trauma Code 1, TC1, activations require significant resources to provide immediate treatment to potentially unstable, critically ill patients. The Kribari matrix method, CMM, and need for trauma intervention, NFTI, are two ways to determine over and under triage in trauma. We study the over-triage rate at a community Level 1 trauma center using these two methods to determine the efficacy of the triage criteria in TC1 activations. Method: a retrospective review of all patients in the trauma registry of a Level 1 American College of Surgeons trauma program from May to October 2021 was performed. Over-triage rates were determined using CMM and NFTI criteria. Results: the over-triage rate of 552 activations using CMM alone was 73%. CMM combined with NFTI resulted in a 56% over-triage rate. Conclusion: the Kribari method can be used to determine the effectiveness of a system's trauma code 1 criteria but cannot delineate which criteria should be reviewed. Locally advanced pancreatic cancer. Is surgical palliation associated with improved clinical outcome relative to medical palliation? Background: the value of palliative surgery in pancreatic cancer is not well defined. Methods: we queried the National Cancer Database for patients undergoing curative intent resection, palliative surgery or medical palliation for clinical stage CT4N02M0 pancreatic cancer. Cohorts were 1:1:1 propensity score matched for comorbidities and stage. Kaplan-Meier method was used to compare overall survival for matched cohorts. Results: 9,107 patients met inclusion criteria, 3,567, 39%, underwent curative intent surgery, 1,608, 18%, surgical palliation, 3,932, 43%, medical palliation. Patients undergoing resection and surgical palliation had significant hospitalizations, 11.0 plus or minus 0.4 versus 10.0 plus or minus 0.3 days, p equals 0.821, and rates of readmission, 8.1% versus 2.0%, p less than 0.001. Patients undergoing surgical palliation demonstrated marginal increases in survival relative to those undergoing medical palliation, 8.54 versus 7.36 months, p less than 0.0001. Conclusion: in patients undergoing care for locally advanced pancreatic cancer, palliative surgery is associated with marginal improvement in survival but significant lengths of hospitalization and risk of readmission. Outcomes following cytoreductive surgery, CRS, and hyperthermic intraperitoneal chemotherapy, HIPEC, for peritoneal malignancies, 10-year experience. Introduction. The treatment of peritoneal malignancies has evolved and select patients can undergo effective surgical therapies. Access to innovative oncology procedures can be improved if programs are developed within and outside of academic cancer centers. We report the creation of a high-volume, comprehensive peritoneal malignancy program developed in a community center. Methods: a retrospective single-site study was conducted using registry data comprising all patients who underwent cytoreductive surgery, CRS, and heated intraperitoneal chemotherapy, HIPEC, between October 2011 to December 2021. Results: 353 patients underwent CRS and HIPEC. 208 patients experienced in-hospital morbidity, 58.9%. Group comparison by disease site, PCI, and the completeness of cytoreduction demonstrated survival differences in mean overall survival and disease-free survival in 1, 3, and 5-year ranges. Conclusions: this study demonstrates that with a standardized protocol and a surgeon-led multidisciplinary team, it is possible to offer safe outcome-driven, complex oncologic surgery in a community-based cancer program. Next article is from World Journal of Surgery. Race and Sex Diversity in Canadian Academic Surgical Societies. Background: it is vital for national professional surgical societies to embrace diversity, inclusion, and equity. This study examines race and sex diversity in 2 Canadian surgical societies. Methods: Websites of the Canadian Society of Cardiac Surgeons, CSCS, and the Canadian Association of General Surgeons, CAGS, and previous programs of their annual meetings were reviewed. Leadership positions, conference speakers, and award winners were categorized by race and sex. Results: white males made up the largest category of cardiac surgery meeting speakers, 73,142, 51%, CAGS committee members, 89,198, 45%, CAGS past presidents, 3843, 88%, and general surgery meeting speakers, 841,472, 57%. Of the 17 members that made up the CSCS Board of Directors and Officers, 8 were white males, 47%, 5 were BIPOC males, 29%, 3 were white females, 18%, and 1 was a BIPOC female, 6%. Of the 42 members of the CAGS Board of Directors and Advisory Committee, 16 were white males, 38%, 5 were BIPOC males, 12%, 17 were white females, 40%, and 4 were BIPOC females, 10%. Conclusions: BIPOC individuals and females are underrepresented in both societies compared to white males. However, in CAGS, improvements in representation can be seen in recent years. It is important that both of these organizations continue to embrace diversity. Preventable deaths in hospitalized trauma patients. Aim: to study the preventable trauma deaths of hospitalized patients in the United Arab Emirates and to identify opportunities for improvement. Methods: we analyzed the Abu Dhabi Emirate Trauma Registry data of admitted patients who died in the emergency department or in hospital from 2014 to 2019. A panel of experts categorized the deaths into not preventable, NP, potentially preventable, PP, and definitely preventable, DP. Results: a total of 405 deaths were included, and 82.7% were males. The majority, 89.1%, were NP, occurring mainly in the emergency department, 40.4%, and the intensive care unit, 49.9%. The combined potentially preventable and preventable death rate was 10.9%. The median, interquartile range, age of the DP was 57.5, 37 to 76, years, compared with 32, 24 to 42, and 34, 25 to 55, years for NP and PP, respectively, P equals 0.008. Most of the PP deaths occurred in the intensive care unit, 55.6%, while the DP occurred mainly in the ward, 50%. Falls accounted for 25% of PP and DP. Deficiencies in airway care, hemorrhage control, and fluid management were identified in 25%, 43.2%, and 29.5% of the DP/PP deaths, respectively. 72% of the airway deficiencies occurred in the pre-hospital, while 34.1% of hemorrhage control deficiencies were in the emergency department. Fluid management deficiencies occurred in the emergency department and the operation theater. Conclusions: DP and PP deaths comprised 10.9% of the deaths. Most of the DP occurred in the emergency department and ward. Pre-hospital airway and in-hospital hemorrhage and excessive fluid were the main areas for opportunities for improvement. Ultrasound-guided vacuum-assisted excision for idiopathic granulomatous mastitis at the abscess stage. Background: idiopathic granulomatous mastitis, IgM, is a rare inflammatory disease of the breast with clinical features that are often confused with those of breast cancer, leading to delayed diagnosis and treatment. This retrospective study aimed to evaluate the therapeutic effectiveness and cosmetic results of drainage surgery using ultrasound-guided vacuum-assisted excision, VAE, for the treatment of IgM at the abscess stage. Methods: the time of recovery, cases of further surgical intervention, and cosmetic results were retrospectively collected and analyzed from patients who underwent drainage with VAE or conventional drainage between October 2017 and August 2021. Results: a total of 65 patients diagnosed with IgM at the abscess stage who underwent drainage surgery with VAE or conventional drainage surgery were enrolled. Overall, 38, 58.5%, underwent conventional drainage surgery and 27, 41.5%, underwent drainage with Va. We found that patients who underwent Va recovered much faster than those who underwent traditional drainage surgery, 30.1 versus 48.0 days. 9. 33.3%. Patients in the Va group required further surgical intervention after drainage, whereas 33, 86.8%, patients in the control group underwent another surgery to resect residual lesions. Additionally, patients in the Va group were more satisfied with the breast appearance, mainly due to less influence of the scars and better symmetry of their breasts. Conclusion. Compared with conventional drainage surgery using Va for IgM patients at the abscess stage improved therapeutic and cosmetic outcomes. Furthermore, postoperative management of IgM is crucial. Surgical prevalence and outcomes in ischemic colitis, a systematic review and meta-analysis. Background/aim. This study reviews the literature to examine the proportion of patients requiring surgical management in ischemic colitis, IC, and identify surgical outcomes. Method. A systematic review of PubMed, Embase, and Cochrane Central Register of Controlled Trials was conducted in accordance with the latest preferred reporting items for systematic reviews and meta-analyses, PRISMA, statement. English language studies and adult patients were included. Studies with fewer than 10 patients and IC post-aortic or cardiac surgery was excluded. We present our systematic review and meta-analysis with pooled proportions of right-sided IC distribution and prevalence of surgical treatment. Results. 23 studies with a total of 12,844 patients were included in the systematic review, with 19 studies and 12,420 patients included in the meta-analysis. 4 studies were excluded from the meta-analysis due to only including specific cohorts of patients, 2 with cocaine-induced colitis, 1 with phleboschlerotic colitis, and 1 with IC associated with acute myocardial infarction. The pooled proportion of right-sided IC distribution was 15%, C 14% to 17%, P less than 0.001, whilst the pooled proportion of surgical management of IC was 15%, C 13% to 16%, P less than 0.001. Conclusion. Prevalence of surgical management of IC is rare. Right-sided IC is associated with higher mortality and higher rates of surgical management. Reporting of surgical outcomes is scant. Thank you for listening to This Week in Surgery, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.